So thank you. I'm very glad to be here and to present my work with you, and also to end this cardiac session. So my work is about cardiac MRI for ICD patients. Okay. So the gold standard to image scar tissue is to use sear or phase-sensitive inversion recovery, or we can also call it bright blood. It provides very good contrast between the healthy myocardium and the injured myocardium. However, the contrast between the scar tissue and the adjacent blood pool is quite poor, and this can lead to some ambiguities for the diagnostic. That's why black blood LG has been developed in order to improve the contrast between the blood and the scar tissue by having both the healthy myocardium and the blood pool being dark, while the scar tissue are bright. But the problem with this method is that we lack the anatomical information. We don't know where this scar tissue is precisely localized, and we need to know that in order to differentiate ischemic from non-ischemic scars. That's why technique called SPOT, which is for joint, bright, and black blood imaging, has been developed by Aurélien Bustin. And the idea is just to acquire a black blood image to get to detect the scar tissue, and then a bright blood image to get the anatomical information, and we can fuse both to have these two information in one image. Now, if we apply this technique, phase-sensitive inversion recovery in patients with a cardiac device such as pacemaker or defibrillator, there will be some local field inhomogeneities because this is a ferromagnetic material, and we will lose some signal around the device, and we will also get some artifacts, hyper-intensity artifacts, as you can see on the images at the top, because of the spatial mismapping of the MR signal. In 2016, Rashid and colleagues, they developed the concept of wideband LGE, where they proposed to widen the spectral bandwidth of the inversion pulse in order to suppress these hyper-intensity artifacts. The idea is when you have the device, some of the spins will process not at the normal frequency, but a different frequency. So by broadening this spectral bandwidth, you can actually invert all the spins, even the ones that are not processing at the normal frequency. So the idea of my project is to combine the SPOT techniques, so joint, bright, and black blood imaging, with wideband LGE for the patients with an implanted cardiac device. The sequence is as follows. So it's ECG triggered. I'm currently working on the 2D acquisition. It's breath hold. It's on the 1.5T scanner. At the first heartbeat, we apply inversion pulse followed by a T2 prep module, and this allows us to get the black blood image. So we have both the healthy myocardium and the adjacent blood pool dark. At the second heartbeat, we apply only a T2 prep preparation in order to get the bright blood image, and we repeated this 5 times in order to increase the SNR. In order to suppress the hyper-intensity artifacts related to the ICD, I implemented the wideband technique in the inversion pulse by broadening the bandwidth from 0.8 to 3.8 kilohertz. So this is the value proposed in the literature, but I also tried to increase it even more to 9.2 kilohertz. In the T2 prep model, I applied the wideband in the 2 refocusing pulses by increasing the bandwidth from 1.6 kilohertz to 5 kilohertz. I first applied this wideband spot technique in the phantom called TIMES. This is a phantom where you have 9 vial tubes representing the healthy and injured myocardium and also the blood. I applied the different sequences. So our reference is the phase-sensitive inversion recovery, where we only have inversion pulse, and also the wideband inversion recovery, and followed by spot technique, standard, and also wideband. For the inversion pulse, I implemented the 3.8 kilohertz value as proposed in the literature, which I named it wideband, but I also tried 9.2 kilohertz, which I named ultra wideband. So for the phantom, I taped the ICD on the side, as you can see on the image, and I also performed the scans without the ICD. I then analyzed the contrast to noise ratio, the contrast ratio, and also analyzed the artifact extents. We then applied this technique in 3 patients. Actually, I changed a bit the slide, and I will show you 4 patients with MRI conditional ICD. So the measurements were performed here at the CHU of Bordeaux. For these patients, we applied the reference here, so without wideband, and then we applied our technique spot with ultra wideband, so where the inversion pulse has a bandwidth of 9.2 kilohertz and the T2 prep refocusing pulse bandwidth of 5 kilohertz. An expert radiologist scored the image quality, 1 being non-diagnostic and 4 being excellent, and also she assessed the overall ICD artifacts. So let's start with the phantom results. Here you can see the different techniques, phase-sensitive inversion recovery, and also spot. So we have black blood and bright blood images without ICD. So this is actually our ground truth for the phantom. We then applied these techniques again when we tape the ICD on the side without any wideband, and as you can see, we see clearly hyper-intensity artifacts on the 3 images, but also ripple artifacts. So this is some bands on the image. For the artifact extent, it was up to 9 centimeters, the artifact, so which is quite huge. Usually the ICD are taped at 10 centimeters around from the heart, can be also less. Using wideband, we were able to reduce the artifacts a lot in the 3 of the techniques, but we still see some hyper-intensity artifacts in all the 3 images. That's why I then further increased the bandwidth of the inversion pulse, and we could remove these hyper-intensity artifacts. But at the end, for wideband and ultra-wideband, the results were very good. The artifacts were really reduced to almost the signal loss, so which is about 2 centimeters. For the contrast ratio, we see that standard SEER provides images with very good contrast between scar and myocardium, so between the yellow and green side circle. But between the scar and blood, it's quite similar, the contrast, whereas with black blood, as you can see, the contrast are dark, and we could improve that very much with this spot technique. And finally, I would like to show you the patient results. So, as I said, we applied in 4 different patients. We first started with the reference here, so without any wideband, it's only inversion recovery. In all of these 4 patients, we can clearly see a lot of artifacts, hyperintensity and also ripple artifacts. In the patient 1, we were able to see the scar tissue, but patient 2, for example, half of the heart is covered by these artifacts, and the diagnostic is not possible. Then we applied wideband for spots. So let's first start with black blood images. In all the 4 patients, you can see the artifacts were suppressed, and that the scar tissue were revealed very nicely. It is shown by the red arrows. The green arrow just shows the lead. And then for the bright blood images, which is important for the anatomy of the patients, we also got very nice results. We don't see any hyperintensity artifacts and ripple artifacts. Then we can combine these black blood and bright blood images in one, which is the wideband spot here, where we have everything in one image. So this technique really provided a better image quality for all the patients, also reduced the artifact severity, and also it was it provided more scar tissue segments. So in conclusion, this technique reduced up to 90% of the artifacts, hyperintensity and also ripple ICD artifacts. It provides a better contrast ratio than the reference sphere. In the patients, we could definitely see more scar tissue than just using the reference inversion recovery acquisition, and with better image quality. In the future, I would like to apply this technique in 3D. I'm currently working on that, but we still have a lot to do. Thank you.